Good afternoon, everyone. I'm Janice Whitaker. It's my pleasure to serve as the administrator for the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Ross and Carol Neese College of Nursing at Penn State. I also want to thank Jenny Rank for her expertise and as a CGNE education program specialist and all of the assistance she provides with our seminars, as well as Amy Caputo for developing the marketing for this series. This program is being sponsored by our center, as well as the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Great Expectations Result in Great Dementia Care, will be presented by Adria Thomas, speech-language pathologist, dementia care educator, and owner of Be Light Care Consulting. Before we begin the presentation, we do have some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is clinical. The presenter listed as disclosed relevant financial relationships with ineligible companies. Adria Thompson, owner of Be Light Care Consulting, has relationships by creating social media content with ineligible companies, including Raz Mobility, Standard, Zinnia, Ageria, Angel Sense, TrueLink Financial, Recall Q, Carewell, Altum View. All the relevant financial relationships listed have been mitigated for this individual. As a reminder, the seminar is being recorded. If you have any questions or comments, you are welcome to put them into the chat, or you can raise your hand by indicating that with the feature at the bottom of your screen, and Jenny will unmute you so you can speak aloud. We will be ending the session about 5 minutes early so that people will have an opportunity to complete the post-event evaluation. It will automatically pop up in your browser when Jenny ends the Zoom link. So be aware of that. If you don't have time in that moment to complete the evaluation, you can save it and do it later, or you will receive an email notification within 24 hours to remind you of that. In order to earn contact hours, we do record Zoom in and out times. You do need to complete the evaluation within 1 week of the seminar. And if you've met those requirements, nursing continuing professional development certificates will be emailed to RNs within a month of the seminar. If you have any questions or concerns, you can always reach out to us at cgne@psu.edu. Next, I'd like to introduce Takshila Dasanaika. Takshila is one of our graduate student affiliates that is currently enrolled in our PhD program. We are pleased that she is very engaged with our center, and we appreciate that she's here today to introduce today's seminar speaker.
Thank you, Janice. Hello, everyone. So it is a pleasure to have Adria Thompson as the guest speaker for the CGNE seminar today. Adria Thompson is renowned for her dynamic approach to dementia care, blending her clinical expertise as a speech-language pathologist with a strong presence in the social media creation, engaging over 310,000 followers. As a national speaker and a trainer, and the founder of Be Light Care Consulting, she specializes in educating medical professionals on innovative, empathetic strategies for dementia care. Adria's training is deeply influenced by her personal experiences, and she is committed to transforming the landscape of dementia care through insightful education and advocacy. Without further ado, welcome Andrea Thompson.
Thank you so much. I'm so excited to be here with you guys today to talk about expectations and dementia. So let's jump in. They did a great job talking about my background. I also want to let you know that I not only do this professionally, but my grandmother has dementia. And so I know what this is like caring for someone with dementia, both professionally and personally. So here's our learning objectives. I'm going to talk a little bit about some foundational information, like the types and stages of dementia, and then we're going to talk about some of the specific cognitive deficits that can impact the way that we interact with individuals with dementia and the way that they experience life. Now, the beginning of this, the title of this program, this webinar is called Great Expectations Result in Great Dementia Care. And the reason that I chose that title is because I believe very strongly in all parts of life that unmet expectations are the root of all frustration and disappointment. Now, like I said, this is true in my marriage, right? So if I had the expectation that every evening when I was finished with work, I walked into my house and my husband has created this beautiful, like, candlelit dinner, 4-course meal. The laundry is done. Everything is perfect. There's music on. I have a bath running for me. If that were my expectations every single day, I would be disappointed. And I might be frustrated. Simply because, not because he's not a great husband, he is, but it's because he lacks the resources, which in his case is time. He works too, so he doesn't have the luxury of time to do that every evening. He also lacks the skills. He's great on a grill, but I don't necessarily think that he would feel comfortable or have the skills to create a big dinner like that for me every evening. There's limitations in what he can do. And because I understand that, I form my expectations around that. And so therefore, when I walk into the house every day and he's like, "What are we going to eat?" And I'm like, "Oh, good question. I don't know." I'm not frustrated. I'm not disappointed. The same is true for individuals with dementia. If we have expectations for their behavior, for their abilities, for their resources that they don't have access to, then we are constantly going to be frustrated and disappointed in them and sometimes in us. So today is all going to be about kind of forming the proper expectations that you should have for the individuals with dementia in your life. I'm going to present to you Bob today. Bob is based on a real patient of mine. This is not his real picture, but Bob was a retired police officer when I met him, and he had just moved into a memory care community that I was working in. He is from rural Kentucky. He was widowed. He has 3 sons. And if we were to describe him, we'd say he's generally pleasant, but he's pretty quiet. And he also has a diagnosis of Parkinson's disease and what's labeled as unspecified dementia in his chart. Okay, so this is what we know about Bob, but I want to tell you also what I heard about Bob. So when I kind of came into the picture, I was given some descriptions of him. We hear, he's quiet and he's pretty reserved, but also his family and the caregivers who were in that memory care community were saying things like that he's unpredictable. Unpredictable in the fact of sometimes he would be aggressive, like seemingly out of nowhere. Like he would be really quiet and really kind and perfectly content, but then all of a sudden he would be aggressive with the staff or with his family. He also was unpredictable in the assistance level that he needed. So when we would help him take a shower, for example, some days all we had to say is, "Bob, it's time to take a shower," and he could do everything on his own. But then some days when we would say that, he would need so much help in turning on the water and getting in and out. He was really unsteady physically. Maybe he was confused and he would sometimes need us to be way more present than others. The staff were saying things like, he does things when he wants to. That's a quote, right? And we've thought this probably before, and we maybe have heard that about people with dementia before, that they do things when they want to. I also heard that he won't listen and he's stubborn. So we might explain something to him or tell him that it's time to do something, and he would completely ignore them, or he would refuse or decline to participate in that thing. He would often refuse help, and they were telling me that he is in denial that he has dementia. So when we would go on a community outing, he was wanting to get up on the steps of the bus by himself when we insisted that we needed to be near him to help him. And he would say, "I'm fine, I have no problems, leave me alone." And he would refuse help when he definitely needed it, when he couldn't get up those stairs to get on the bus. He also would make some sexually inappropriate comments to the staff, and his granddaughter even reported this at home at times. So here's all of the complaints, concerns, whatever you want to label them. These are things that sometimes people will call behaviors, right? This is the reality of what it's like to care for Bob based on the reports of his friends and family and staff members. So we're going to get back to Bob, but I want to give you some information that we're going to apply to his situation. And we're going to lay the foundation of what we're talking about today so that we have the proper expectations. In order to do that, we have to start with defining the term, what is dementia? Well, according to the National Institute on Aging, dementia is the loss of cognitive functioning, for example, thinking, remembering, or reasoning, to the extent that it interferes with a person's daily life and activities. So you might Google what is dementia and you see different variations of this description, but there are always two criteria. The first is that a person has a change in their brain that affects their ability to think, okay? So we have a change in the brain. And the second criteria is that it's severe enough to interfere with their life. Now, if someone is experiencing a change in their brain that's affecting their life, then they could be diagnosed with what's called dementia, a very general term. Earlier, I said that he was diagnosed with unspecified dementia, and that is often the case for many patients. They just have a general term that's applied to what they're experiencing. However, under that umbrella of dementia, the changes in the brain that affect their daily life, we have specific diagnoses that fall under that. And we're going to talk about 4 of those today. I want to share with you the predominant symptoms of 4 different kinds of dementia. When we diagnose a specific type of dementia, it's often based on ruling out other things. So there are some things that are called reversible dementias or pseudo dementia, which basically means that there are other medical events and diagnoses that might have a symptom that mimics dementia. For example, untreated hypothyroidism can cause cognitive confusion, disorientation. Also, infections like urinary tract infections, brain tumors, vitamin deficiencies, all of these things, and there's a list of many more, can cause changes in someone's brain that affects their life. But once they are seen by a doctor, they're determined that it's something that can be treatable, that potentially could be reversible. Depression is also a pseudo-dementia. Now, if all of those things are ruled out, and sometimes we do brain imaging and other testing, we might find one of these 4 types of dementia, but really there are over 100 types of dementia. These are just the most common. So Alzheimer's disease, the first and most predominant symptom that we see in individuals with Alzheimer's disease is short-term memory loss. Now, this is the most common type of dementia, and this is the one that we see depicted most often, like on TV and movies. It's just that general forgetfulness of not remembering things that people have told us, not remembering where we put things, asking repeated questions, or telling repetitive stories. Now, the next type of dementia is called vascular dementia. This is caused by blood flow changes in the brain. So places in the brain that's either getting way too much blood, like a hemorrhage, or areas of the brain where blood flow is being cut off. And either of those situations can cause damage. So many of the people who have vascular dementia will have a past history of a stroke or a mini stroke. Now, it's hard to say the exact symptoms that we're going to see in this type of dementia simply because it matters where in the brain the damage has occurred. So if someone has damage in the frontal lobe of their brain, like a stroke or a mini stroke, or someone who has the same but in the back of their brain in the occipital lobe, those two people are going to look very different. Their symptoms are going to be very different because it's affected their brain in different places. So symptoms will reflect where the damage has occurred. But if I were to give you 3 general symptoms that we might see in this type of dementia, we're going to see change in personality, slowness in thinking, and confusion. The next type of dementia I want to talk about is Lewy body dementia. Now, this is often associated with Parkinson's disease. This is simply because it's caused by the same etiology, these Lewy body proteins in the brain that shouldn't be there and quite honestly just wreaks havoc in the brain. If the symptoms that are expressed because of these Lewy body proteins in the brain cause physical symptoms first, we might call that Parkinson's disease. Those physical symptoms we see are short shuffled steps, freezing of movements where they can't get their foot to pick up. They might have a stooped posture. They start to have a flat affect, so they're not using their facial muscles very much. They seem very what we call masked faces, which is just no expression or emotion in their face. We might see tremors. We will see in their voice that they are quieter, but then also they're not as clear in their speech. Those are all physical manifestations of Lewy body proteins in the brain. Now, if we see cognitive symptoms showing up first, then we usually will be calling that Lewy body dementia. So the 3 symptoms that we see most often and first in Lewy body dementia are sleep disturbances, which is called an REM sleep behavior disorder. This is when while they're sleeping, they're acting out their dreams. So they're really fitful sleepers. They might fall out of bed frequently. We also see visual hallucinations, which is where you see things in your environment that aren't actually there, but they seem just as real as anything else in their field of view. These are often seeing people, animals, children, shadows, or bugs. Those are some of the common visual hallucinations that happen. And then we will also see fluctuating alertness. So moments where that person is really lucid, they're really with it. And then moments where they're really confused, disoriented, scared, and they can kind of fluctuate back and forth without warning and seemingly out of nowhere. The next type of dementia we'll talk about is frontotemporal dementia. And frontotemporal dementia is actually an umbrella term in and of itself. So frontotemporal dementia has 2 subtypes, the behavioral variant, which causes changes in a person's behavior. That makes sense, right? That is where we see changes in personality. So that person might be socially inappropriate. They might start to have compulsive behavior or get fixations or obsessions with things. This might look like someone developing a gambling problem, or they start hoarding, or they develop an eating disorder because they're obsessed with working out or their weight, or they might start picking up drug or alcohol habits that really start to impact their health negatively. We also see a lot of impulsivity, which is tied to that, where they just react with instinctual kind of feelings. The other subtype of frontotemporal dementia is a language variant, which is called primary progressive aphasia. And with this kind of frontotemporal dementia, we're going to see communication impacted first. So not just a person's ability to speak, but their ability to read, write, and understand other people when they speak. So as you see, there are many different symptoms that are very specific to the diagnosis that they have. When we hear about dementia, we often think about memory loss, but quite honestly, that is not a symptom for every type of dementia. I mean, Lewy body dementia and frontotemporal dementia does not present with short-term memory loss at the beginning of the disease. And so often these people are misdiagnosed or misunderstood as having a mental health challenge or diagnosis. So if we understand the type of dementia someone has, then we can have more specific and more appropriate expectations for the way in which they present themselves. Now, not only are there different types of dementia, but there are different stages of dementia. And there are many scales that exist that describe the changes someone experiences over the course of having dementia. And none of these scales are better or worse than the others. They just are different. You might hear a doctor say mild dementia, moderate, or severe dementia. It's kind of a three different separate types of ways to describe where someone is in their progression. We also might hear early, middle, or late dementia. There's also a scale called the Allen Cognitive Levels, but this scale is called the Global Deterioration Scale. This was developed by Dr. Barry Reisberg in the 1980s, and it's very well known. It most closely describes the changes that happen with Alzheimer's disease because it is really the most predictable type of dementia, the most like the slowest kind of changes that we will see. So I'm going to go over this pretty quickly. This could be an entire presentation in and of itself, but just know this term if you are interested in learning a little bit more. It's a scale from 1 to 7, 1 being no cognitive deficits at all. This is baseline. This is before any changes in the brain happen at all. 7 on the other side is the most severe. Stage 2 is what we call age-associated memory impairment. So this is what we should expect with normal aging, which is basically you might notice changes in your thinking, but other people don't. And even if you were to be giving a very thorough test, you wouldn't be able to see any changes. Stage 3 is mild cognitive impairment. This is a diagnosis you can get. We also call this MCI. This is where other people are starting to notice. They are noticing that you're different, but you're still able to operate and care for yourself pretty well. You can compensate for the challenges that you're experiencing. Stage 4 is actually where we get a diagnosis with dementia because we fit that second criteria where it's starting to affect their everyday life. So by the time someone is diagnosed with dementia, there's been a lot of changes in their brain at this point. In stage 4, they might have forgetfulness of recent events. So they might know big events, but not the details of it. They're also, because many responsibilities are having to be taken away from them, they can no longer manage their own medication. They can no longer pay their bills. Maybe they can no longer drive. People might respond with anger, frustration, or isolation and depression. In stage 5, this is considered moderate dementia. At this stage, someone can no longer survive without assistance. Left to their own devices, they would endanger themselves, either by wandering out of the house, by neglecting themselves, taking too much or too little of medications. They're going to have more disorientation to time and place. They're going to have more difficulty with communicating. And this is where we start to see they kind of break down at the end of the day. They get more restless, more confused, in which is what we call sundowning. Stage 6 is moderately severe dementia. At this point, communication is going to be pretty not functional. So they might be able to verbalize and say words, but they're not able to necessarily communicate their wants and needs in an effective way. We also see them start to really lose awareness of their surroundings, which result in some of the behaviors that we referred to earlier. And stage 7 is severe dementia, where they lose capacity to really care for themselves at all. So other people are having to take full responsibility of helping them eat, helping them walk or move around, and taking care of any needs that they might have. Once again, it's important to know where someone falls on this scale so that we have the proper expectations. If we are presented with someone who is in stage 6 and we expect that they are able to operate, communicate, and interact with their life in the way that someone in stage 4 does, we're going to be frustrated and we certainly will be disappointed. And we're not going to be able to meet their needs. So, we have types of dementia, we have stages of dementia, but then there are specific changes that happen in someone's brain that we need to know to be able to recognize and to expect so that we can engage with them and not be surprised when we see these things happen. The first two I want to talk about are changes in attention and memory. Now, these two go hand in hand because if you're not paying attention to something, then you're certainly not going to remember it. So not only do we have damage to the part of the brain that can really house our memory, which is the hippocampus, but also we have changes in attention, which limits the experiences we have to even get to that part of the brain. So to prove to you that attention and memory are very closely linked, I'm going to quiz you for a second. So get your chat ready. I want you to see these 4 pictures. I showed you a picture of Bob earlier. Look to the left side of him. We have a picture kind of on the first picture. Number 2, we see a curtain. Number 3, we see an open window. And number 4, we see a plant. Okay? Tell me in the chat, which was the picture I showed you? We're going to test your attention and memory. See what you think. Okay, we see number 2, number 4, number 2. Okay. All right. So we see lots of different answers, right? Is it because some of you have dementia and others don't? Certainly not. It's because this was not important to you. You didn't pay attention to it. So therefore, you're not remembering. Let's see. A couple of you got it right. It was the green curtain. This is the picture I showed you earlier. So the correct answer was 2. You can give yourself a pat on the back if you got that right. But for those of you who got it wrong, that's okay too. You just didn't pay attention. It wasn't important. You didn't know you were going to be quizzed on it. So that's all right. All right. And yeah, good guess. Maybe you just got a good guess. 2 other things that happen that work hand in hand, it changes in reasoning and problem solving. So reasoning is where we think about something in a logical way. If you know someone with dementia, you know reasoning can be impaired because they are not good at reasoning. We also see problem solving deficits. So let me show you what this looks like. We often put very high expectations on someone with dementia's ability to reason and problem solve without even knowing it. So let's say someone that you love, that you care for, that you know, who has dementia, walks out of the room with these white shorts on. And you say, "What are you doing? It's snowing outside." For you, that seems like a perfectly reasonable way to react, to a way to communicate with them. But this is requiring them to reason and problem solve. And I'm going to show you what this looks like. So for them to hear this with dementia, they have to go to understand what you mean. They have to go through this thought process. Okay, so they must see something that's inappropriate. And they're likely talking about my appearance because it's the only thing they can see. So they're probably referring to my choice of clothing and snow. Snow outside means that it's cold, and so my clothing must not be appropriate for cold weather. So my shirt has long sleeves and it covers my arms, so my arms would not be exposed to the cold, so it's probably not my shirt that's inappropriate, but my pants are short and my bare legs would be exposed to the cold temperature, so it must be that my shorts are inappropriate. This happens in our brain immediately. We don't We don't consciously go through all those steps because we understand when we're neurotypical what someone is communicating to us. What are you doing? It's snowing outside. This is reasoning. This last part, so I must need to change into long pants, is the problem-solving part of things. We often are communicating to someone with dementia in a way that's expecting them to reason and to problem solve when they can't. So if I said, what are you doing? It's snowing outside, and they just continue walking and go outside, we would be frustrated and disappointed if we didn't realize that this was an inappropriate expectation for this person to understand what we mean. Now, orientation. I vastly underestimated the importance of orientation, not only in what we call appropriate and inappropriate, but also when it comes to compliance with what we need them to do. Let me show you. You see this picture? This lovely couple going for a walk? You don't have to put it in the chat. You can just just think about it. But do you think that they are dressed appropriately for the situation? No. Right? They're wearing short sleeves, they're wearing shorts, they're going to be freezing. So we would look at them and say, what are you doing? You're dressed inappropriately. However, if we were to see them like this on this beach where it's warm, would we say that they're appropriate or inappropriate? Appropriate. This is an appropriate way to dress. Now, did their behavior change? No. Did their choice change? No. It's just the context and the environment around them that changed. Now, I want to show you what I mean by this when it comes to dementia, because it's not necessarily that people with dementia are acting inappropriately. It's just that the way that they're acting is not in line with the environment or the context that they're in. So, when we talked about Bob and we said that he was making sexually inappropriate comments, think about your life. And in times where, let's say you're in the shower and you're taking a shower and someone enters into your bathroom. When has this happened to you in your normal life? Probably if someone of the sex that you're attracted to, if they walk into the bathroom while you're showering or doing intimate tasks, it's likely that you have some kind of romantic relationship with that person, some kind of intimate relationship with that person. So we can also see this when we wake up in the morning. If we were to open our eyes and see someone of the sex that we're attracted to in the bedroom with us, as long as they weren't breaking in and trying to kidnap us, we might think, oh, okay, look, the only times this has happened in my life is when I'm in a romantic relationship with that person. And so when we take that into consideration and we look at Bob, maybe he's responding to some of these female aides in these intimate moment tasks, in this context, and saying, hey there, baby, why don't you climb into bed with me? When that would actually be really appropriate in other times that he has experienced this moment. But in this context and in this moment, it's not appropriate, right? But it's not that he's making this terrible choice. It's that he's disoriented to the setting that he's in, okay? Also, when it comes to compliance, if I were to ask you, we see the bathroom on one side and then the Ziploc bag aisle in the grocery store, which of these places would you be more willing to take your clothes off? I'd venture to say that most of you, no judgment if you don't mind taking your clothes off in the grocery, but most of you would be more comfortable in the bathroom. That's because, not because it's physically easier to take your clothes off in a bathroom, but that you feel safer there. Now, for someone with dementia who has disorientation, they might not understand the difference between the bathroom and a grocery store. And so they might feel as unsafe taking off their clothes in the grocery store and feel as unsafe doing that in the bathroom. Or vice versa. Maybe they take their clothes off in the grocery store because they're disoriented and they feel as safe doing that as they would in the bathroom. So understanding where we are is not just being, okay, oriented times 3, check it off. What does that mean What does that mean when they're disoriented, and how might that affect their ability to interact with their environment? And how is that going to be interpreted as inappropriate or appropriate? There's a few more symptoms here I want to talk about. The first being a term called anosognosia. Now, anosognosia is being unaware of your deficits. This is different than denial. So let's say I were to ask you to say, okay, give me a thumbs up. Zoom sometimes, there it goes. Zoom gave me a thumbs up. Okay, so if I were to say, give me a thumbs up to someone who had their thumb amputated, I might get frustrated. Come on, give me a thumbs up. And they're like, I can't. Like, no, come on, give me a thumbs up. I'd be frustrated because my expectations would be that they give me a thumbs up, they're going to do it back to me. But I'm unaware of the fact that their capacity is different. This is true for anosognosia. It's not that they are in denial about their dementia. If they are in denial of dementia, that means they have the capacity to understand they have dementia, but they choose not to. Anosognosia says they don't even have the capacity to understand they have dementia. So therefore, they don't. It's not there. So if we say, Mom, you need to go to the adult day center. You need to because you have dementia. You can't stay home by yourself. If she doesn't agree with you on that foundational piece of information that the reason she needs to go is because she has dementia, then she's never going to be on the same page as you. So having the expectation that they agree and that they can acknowledge that and understand it when they can't is going to lead to frustration. We also will see disinhibition for many people, especially with frontotemporal dementia at the beginning, but we will see it for others later in the disease. But this is where they react without restraint. So they're going to be rude. They're going to say things inappropriate. They're going to behave in those impulsive kind of ways that we feel that we don't always follow through with. So we will see impulsivity. We also will see confabulations. Confabulation is basically where the brain fills in gaps with memories that's fabricated without their awareness. So basically, they're lying without knowing it. So if we say it's time to take a shower and they say, no, I already have. If we think that they're lying, we think that they know the truth and they're just choosing to tell us something different, we're going to be frustrated. But if we understand that their brain has filled in the gap of not having any memory of this morning, but they know that their entire lives they always showered in the morning, then their brain's going to tell them, yeah, you showered in the morning. You always shower every morning. It's a confabulation, not a lie. The last thing I want to tell you here is a term called paratonia, which I'm going to show you what it means in this video.
When someone with dementia is resisting when you're trying to help them, it actually might be paratonia. So let me tell you a few things first. This is called active movement, where I am actively using my muscles to move my arms the way I want. And this is called passive movement, where someone else is lifting my arm without me engaging at all. So paratonia is defined as active resistance against passive movement. As he's trying to passively lift my arm, I am actively resisting against it. It has been seen in about 5% of people with mild cognitive impairment and up to 100% of people with advanced dementia. So paratonia is a reflex in the later stages of dementia. And by definition, a reflex is something you cannot control. So as he's just trying to lift me off the couch, all of my muscles are actively resisting against him. When he pulls up, I push down. If he pulls forward, I push backwards. Many times these same people who are so difficult to lift can stand up themselves and walk just fine. But that's because it's an active movement and nobody is passively moving them, kicking in the paratonia. When someone with dementia is resisting.
Okay, so what do we often call paratonia if we don't know what it's called or if we don't know what to expect it? We might call that being combative, being resistant, being non-compliant, being difficult. I want you to understand like what these phrases, like what this terminology can do. Here's another list of a ton of terms. You can take a picture of this screen, you can screenshot this, I'll leave it up for just a second. But these are all terms of things like paratonia, like anosognosia, these more medical terms, to explain what we're seeing in individuals with dementia. If we have a better understanding of what we should expect, we can meet them with more compassion and empathy. Here's Bob. Bob, this is a true story, unfortunately. He had a situation. I came in the next day, and this is what I was told. Okay, last night, Bob saw a staff member swinging a phone charger around. She was standing outside the nurse's station talking, and she was swinging a phone charger around. He started shouting commands at her and attempted to put her hands behind her back and push her into a room. Now, if you remember from earlier, he's a retired police officer. So this was instinctual for him. This was his long-term memory kicking in. He saw something he experienced as a threat, as something dangerous. Multiple staff members responded because there was yelling. They surrounded him. They started, Bob, stop, get off of her. They're physically trying to interfere into this situation. As you can imagine, what is like a police officer's worst nightmare? Being ganged up on and surrounded without backup. So what do you think happened? Things escalated. They ended up having to call 911. He was transported to the hospital. He was prescribed a medication called Haldol, which it's important to know for individuals with Parkinson's disease and Lewy body dementia, Haldol is contraindicated. That means that it is absolutely not a medication that they need to have in their system. It can cause further decline, and that decline can be permanent. Why this was prescribed, I don't know. Something terrible happened in this exchange. Maybe they didn't see his diagnosis. Maybe they didn't know this contraindication. But 1 week later, he ended up passing away from aspiration pneumonia because he lost his ability to swallow. He was, from that medication and that hospitalization, his motor abilities declined rapidly. This is a sad, terrible story, but I tell you this simply because staff had the wrong expectation for him. We go back to these concerns. If we had better put terminology and training and understanding and education to what these general descriptions of him actually meant, maybe this would have looked different. So instead of him just saying, oh, he's unpredictable, we know with Lewy body dementia, which is probably the type of dementia he had related to his Parkinsonism, it's expected to have fluctuations. That is one of the top 3 symptoms. We should know that that's going to happen. When he had that aggression, maybe he was experiencing a hallucination. Maybe he was experiencing a delusion. Those are very common for people with Lewy body dementia. He flipped quickly. His assistance level changing, that's to be expected with Parkinson's disease. Saying things that he does it when he wants to, once again, it's not necessarily when he wants to, it's when his disease allows him to be functional. Saying things like he won't listen and he's stubborn. If we understood that maybe he has a comprehension language deficit, as a speech therapist, it's possible that he was having difficulty understanding. So it's not that he hears them and he chooses to ignore or to defy their commands. It's that he didn't understand what they were saying. Instead of saying that he refuses help and he's in denial, maybe he was experiencing anosognosia. And instead of saying that he was making inappropriate sexual comments, we might be able to better understand that he was misinterpreting that context because he was disoriented. But also we know for many people with Parkinson's medication, hypersexuality is a common side effect. So if we knew to expect these things from him, could we have managed them in a better way instead of being completely caught off guard and without any tools? I don't know. We need to rewrite the narrative. We need to say things, we need to use terms, because when we talk about person-centered care, we need to focus on the person and not the deficits. We don't need to use that medical terminology. I disagree, because it's not until we separate the person from the disease that we really are able to see that person better. So if we can separate them and say, okay, this is the disease happening, it's not the person, I think we can meet them with more compassion and empathy. All right, here's my references. This is where we take questions. I know we talked about a lot of things, but let me know any questions you have in the chat or anything that stood out to you.
Adria, thank you so much for that really wonderful presentation. I can see why you have over 300,000 followers on social media. You provide such clear, understandable information. You have such a positive, practical approach. I know I enjoy, that your educational posts on social media, and to start us off, looks like we've got some things coming in, but to start us off real quickly, I saw a post the other day that was, again, very positive, because there's a lot of stigma related to moving into a long-term care community. And as a former director of nursing, I really appreciated that you talked very positively about why care partners who often feel guilty or have a negative view of long-term care might want to consider having their loved one cared for in a long-term care community earlier on than waiting. Can you comment a little bit about that?
Yeah, I think long-term care is a tool in our toolbox. I know that my own grandmother is living in long-term care. I've spent my entire career working in long-term care. So it is very important for me that we can change the stigma that exists, because it is so important to know your options and to be able to make good choices if it comes to the point of using long-term care communities. So if we can start the transition into long-term care earlier, there can be benefits. Like they can have more skills in their communication so that they can advocate for themselves and say, hey, you know what? I don't like my eggs scrambled. I like them fried. Whereas if we wait longer, they might not be able to express that. It also allows them to form relationships, not only with the staff members, but other residents. Having more cognitive abilities can also allow them to learn to navigate the whole building a little bit better. So there's a lot of benefits in doing that process earlier and not just waiting until the last possible moment.
So there's all kinds of wonderful positive comments in the chat. Donna Fix says, great presentation. Unfortunately, not an unusual case and so sad. We can and must do better and are thankful you and others are getting the word out to rewrite the narrative, and behavior has meaning.
Absolutely.
You talked about focusing on the person, not the deficits. I think that is such a key understanding. Marianne Ventura says, this was amazing, all in capital letters. So many clear points and presented. Sarah Songer says, what might you have done differently to manage Bob's episode? What's the next chapter?
Yeah. So in that moment, Bob was experiencing, he was seeing this moment as someone was in danger. And as a police officer, and in that moment, he thought he was protecting those other staff members. So we need to be in that world, in that situation. If it really was how he was interpreting it, what would be a way that would make him come down? Certainly it wasn't surrounding him. It was, Bob, thank you. Everything's okay. We've got this under control. Maybe even from the description, he wasn't being really forceful or like hurting her when he was putting her arms behind her back. Let him put her into a room and close the door. That was going to be what made him feel safe. But what we need to do in moments where someone is heightened and feeling unsafe is to make them feel safe and loved. That needs to just be plastered across our foreheads. How do we make them feel safe and loved? And sometimes, as cheesy as it sounds, and you might think that would never work, it's to look them in the eyes and say, Bob, we're safe. Everything's okay. sometimes that's all they need.
That is beautiful and so simplistic in nature, and that isn't that what we all want as human beings, to feel safe and loved. So thank you for sharing that. So Diane Bartman says, what a terrific explanation of how to treat a dementia person as a person and not as a resistant person due to their behavior. Donna also mentions, we interview staff about delirium and dementia, and they often are afraid of behaviors. I could expand on this off mute, but how do we help staff not get fearful and take time to think and breathe in cases like Bob and to avoid overreacting?
I think it starts with education and explaining, and just like this presentation, from the very beginning to say, this is what we can expect. Individuals with Lewy body dementia and individuals with Alzheimer's are going to look very different. And from the get-go, if they don't know what each resident in that building, what the differences in their dementia is, then they are not going to know that they need to operate and communicate with them differently. And that's really where I have a issue with sometimes people who use person-centered care to use the excuse that we don't need to have medical conversations or not to talk about people's diagnosis. I think it's important so that we can see that person separately. So I think it starts with education. Hey, people with Lewy body dementia have hallucinations. This is what it could look like. I think also having some role playing can be helpful, and forming relationships with residents so that we know, not necessarily, we can take information from smaller situations that we've had with Bob and then interpret that to some of these bigger explosive moments. If we have those connections, I think it can really help.
Thank you. So Ahmed is also saying, wonderful and clear presentation, asking, does the pre-existing relationship predict resistance to care and anger in the person with dementia? So how's the relationship? You mentioned the importance of building connections and relationships. How does that relate to a pre-existing relationship?
Certainly. Now, if you're caring for a spouse, a parent, a sibling, you have a pre-existing relationship that not only includes habits and the way that you interact with each other, but the way that you communicate with each other. There's a lot of history there, and long-term memories can persist. So they might still engage with you in the way that you always have. So if you've always had a tough relationship, if there's always been friction, then in dementia, there likely might still be friction there. So some of those things might carry over. But I think it's important to know to recognize if you're not the best person to de-escalate them and acknowledge that, because sometimes we are. Sometimes even in professional settings, there are certain residents that I really click with and some that just don't like me for whatever reason. It's not my fault, but maybe I reminded them of someone or whatever. We need to acknowledge when we might not be the best person to interact or to de-escalate them. Sometimes we're the only person. That might mean that we just need to remove ourselves from the situation and give them time and space. So I think just being aware of your presence and what that does for that person, so that, we can make better decisions on what to do.
Yeah, so not only adjusting your approach, but also trying not to take it personally.
Yeah.
Which I when you were quoting things that staff often say, one that came to mind for me was, they're just looking for attention.
Yeah. Oh,
That one.
God.
Can you comment about that? Why, some of the, observations we might have of a person with dementia where a staff member might think they're looking for attention.
Yeah. Well, I think when they say that, they mean it in a negative way, but they might be looking for attention. They might be needing help. They might have a need that a need that needs to be met. And so when I hear staff say that they're looking for attention, then I want to say, like, well, what do you mean by that? You just think that they're doing it without any purpose, but maybe they are needing attention. Don't you sometimes? Like, don't you, if you couldn't communicate, if you couldn't get up and get yourself a glass of water, what else would you do? You would draw attention to yourself. So yes,
Yeah.
you mean it in a negative way, but potentially you're right. But
Right,
that's
they
not to
could be
mean that we
bored, they
don't.
could be needing some
Yeah,
connection with a
yeah.
human being. I'm afraid we're getting close to time, but I'm going to ask you one more question that I think will help kind of summarize a little bit of this. How can we help you spread the word to families and at-home care partners with this life-changing information?
Oh, that's a great question. So I definitely, on my social media, I have videos, but I think, so my message specifically can be shared through that, but this message can be shared by using the right terminology. So whether we are personal caregivers or we are professional caregivers, we need to check ourselves when we're talking about people with dementia. Are we saying things like they're just being difficult? They're just trying to make my day hard. They are just seeking attention. They're fighting me. They're resisting me. They're refusing. We need to be more thoughtful. As a speech language pathologist in the buildings I worked in, I took it very seriously that any time that I communicated about a resident with dementia, that I was using specific terminology. And if someone didn't know what that meant, we can talk about that. That's further education, but just having a not only positive stance, but also an accurate one is really important. So just continue to do your best. Here, I'll put up my information. If you have any questions, if you want to reach out to me, feel free to do so. I love communicating with caregivers, professional or personal.
Well, and we love communicating with you, and I hope that we can stay connected in all kinds of different ways. This has been fabulous, Adria. Thank you so much for providing a seminar for us today. I'm sure on behalf of all the participants today, we all are very thankful for your presence and all your insights and expertise that you shared with us today.